Statins, once hailed as a revolution in cardiovascular medicine, have become one of the most prescribed drug classes in the world, not only for patients recovering from heart attacks or strokes, but increasingly for healthy individuals with no prior history of cardiovascular disease. This expansion into what is known as primary prevention has blurred the line between necessary medical intervention and commercially driven overreach. While statins like atorvastatin Lipitor, rosuvastatin, Crestor, and simvastatin Zocor can significantly reduce the risk of recurrent cardiovascular events in high-risk patients, their widespread use in people with little more than elevated cholesterol levels, absent other risk factors, has generated intense debate. At the heart of this debate is the tension between population-wide risk reduction and individualized medical need, a tension that has been heavily influenced by profit-driven incentives and strategic messaging from the pharmaceutical industry. The science supporting statins in secondary prevention, where someone has already suffered a cardiac event, is solid. Statins lower LDL cholesterol and, in doing so, reduce the risk of future heart attacks and strokes. But in people without diagnosed cardiovascular disease, the absolute benefit of statin therapy is far smaller. For instance, large meta-analyses have shown that for every 100 people like this treated with statins over 5 years, only about one cardiovascular event is prevented. The other 99 gain no measurable benefit but are still exposed to the drug's risks, which can include muscle pain, liver enzyme abnormalities, increased diabetes risk, and cognitive complaints. Yet this limited benefit is rarely made clear in direct-to-consumer advertising or even in physician conversations, where statins are often framed as a routine, almost benign safeguard against heart disease. This shift didn't happen by accident. It was the result of deliberate framing by pharmaceutical companies and aligned medical voices. In the late 1990s and early 2000s, blockbuster statins like Lipitor became household names not just because they worked, but because they were marketed directly to the public and promoted as necessary for maintaining heart health. Television ads encouraged viewers to know their number, LDL cholesterol, and talk to their doctors about getting it down. The message was simple: high cholesterol equals heart disease, and statins are the solution, even for people without symptoms, comorbidities, or elevated risk according to traditional metrics. This expansion into primary prevention vastly increased the pool of eligible patients. Guidelines from influential organizations, such as the American College of Cardiology and American Heart Association, began to recommend statins for anyone whose calculated 10-year cardiovascular risk exceeded certain thresholds, even if they had never experienced a cardiovascular event. These risk calculators often heavily weighed age and cholesterol levels, which meant millions of older adults with otherwise clean bills of health suddenly qualified for long-term statin therapy. The pharmaceutical market responded with aggressive marketing, lobbying, and ghostwritten journal articles that painted statins as universally beneficial. The economic implications were enormous. Lipitor alone became the best-selling drug in history, raking in over $125 billion during its patent-protected lifespan. The global statin market remains worth over $15 billion annually, despite the drugs now being available in generic forms. These profits are driven not just by the size of the market, but by the fact that statins are typically taken daily for life. Each new person placed on a statin regimen becomes a long-term customer, often without ever having been seriously ill. The public health justification is based on the idea that small risk reductions across large populations can yield large societal benefits. But that population-based logic doesn't always align with personal benefit. A person taking a statin for primary prevention may feel secure, believing the drug is protecting them from a heart attack, when in reality their individual absolute risk reduction might be vanishingly small. Worse, this sense of protection can sometimes displace more impactful lifestyle changes, like quitting smoking, improving diet, or exercising, especially if the statin is perceived as a simple fix. There's also the issue of side effects, which are often downplayed. While some argue that statins are among the safest drugs in use, real-world data show that a significant number of users experience muscle-related symptoms, cognitive complaints, or blood sugar dysregulation that can lead to type 2 diabetes. These issues are frequently dismissed in clinical trials as rare or subjective, but patient reports suggest they are underreported or poorly addressed. And when they do occur, patients may be told the symptoms are unrelated, or worse, pressured to continue the medication for their own good, even when the potential benefit is marginal. The push for primary prevention has also been fueled by the redefinition of disease. High cholesterol, once a risk factor, is now treated as a disease entity in itself. The National Cholesterol Education Program, for instance, has issued increasingly aggressive targets for LDL levels over the years, some of which are nearly impossible to reach without medication. These targets have been influenced by panels that included experts with financial ties to drug companies, raising concerns about conflicts of interest in the very recommendations that expanded statin use. This pattern, identifying a risk factor, medicalizing it, then offering a lifelong pharmaceutical solution, has become a blueprint for commercial success in modern medicine. Statins are perhaps the clearest example of how the boundaries of disease can be stretched not only by diagnostic enthusiasm, but also by an industry eager to convert more people into patients. In the end, statins are not snake oil. They have a clear role in cardiovascular disease management. But their aggressive expansion into healthy populations through primary prevention messaging has turned a narrowly indicated therapy into a mass-market commodity. The result is an erosion of informed consent, a public that overestimates the drug's protective powers, and a healthcare system increasingly shaped by the imperatives of pharmaceutical sales rather than patient-centered care. The promise of preventive medicine has been co-opted not to empower individuals with nuanced, evidence-based decisions, but to broaden the consumer base under the guise of staying healthy.